Hey guys, welcome to my YouTube channel. Let's revise medicals. I am your study buddy Vaishnavi, and today I am revising for my upcoming exam post end pediatrics. And so I want you all to revise with me for the same. I hope these series of videos on clinical pediatrics will be really helpful for your upcoming post end exams, term exams, for your prelims, and university exams as well. So let's go. We are dividing this clinical pediatrics videos mainly into four parts. Firstly, we'll be dealing with history taking, in which we'll see what is the pattern of taking a case in pediatrics, and we'll simultaneously look upon the questions that probably would be asked for you in your viva exams. The second video will go for physical examination. In the third video, we'll see about the growth and development, anthropometry, developmental milestones, and etc. etc. And in the fourth video, we'll see some important part from systemic examination. Also, many parts in these topics are quite intelligent, so please do watch all the videos for the same. I've made sure that I won't really skip any topic from clinical pediatrics as far as it is really important. And if you really like my content after watching the video, you can really like, share, subscribe. Because, guys, it really takes a great deal of time, efforts from me to do the videos for you all. So, please support. Don't forget to subscribe. And for those who have, thank you. So, to start with history taking, we'll look at the format of history. So, firstly, we'll take the name, age, gender, place, and informant, followed by presenting complaints, followed by history of present illness, past illness, history of contact with non communicable diseases, antenatal history, birth history, neonatal history, developmental history, nutritional history, immunization history, personal history of allergy, family history, social and environmental history. Family history is of importance if you really suspect the case to be a congenital disease, and if not, family history does not really play a huge role. For physical examination, we will go with general examination followed by vital signs, anthropometry, and systemic examination. After which we'll make a provisional diagnosis and we'll consider all the differential diagnosis. And we'll start with the pattern, in which we'll write X-year-old male or female child, name, residing at, dash by religion, informant being XYZ, was brought to a hospital on date with chief complaints of 1, 2, 3, and thus will start our case. So, why is the name important? It's for identification of the patient, it increases the confidence of the patient, and we can also indirectly know the religion of the patient, and thus if there is any relevance to the case. Secondly, age. So, why is age important? We need to know certain diseases that are prevalent in children of specific age group. For example, ventricular septal defect presents within 4 to 6 weeks of life, whereas atrial septal defect does not really present until adulthood. So, if your case is related anywhere to CVS or cyanosis, they may ask questions that heart conditions leading to cyanosis at birth. They are tricuspid atresia, transposition of great vessels, total anomalous pulmonary venous drainage, truncus arteriosus, tetralogy of Fallot. Next, gender. For example, atrial septal defect and pulmonary hypertension, primary pulmonary hypertension, it is common in females compared to males. And there are certain genetic disorders like Turner syndrome, Rett syndrome, rheumatic chorea, which are seen in female, whereas Klinefelter syndrome, Fragile X syndrome, color blindness, hemophilia, these are seen in male. Other disorders like cleft palate is seen in female, whereas cleft lip is seen in male. Place of residence, as we all know, it is important for us to know because there are certain diseases that are endemic in certain regions. like endemic goiter is common in hilly areas. Patent ductus arteriosus is common at high altitudes, and so on. Nextly, informant. The informant is the person who presents the history on the behalf of child. We need to know here the reliability of informant. The informant should be reliable. So presenting complaints are the chief complaints given by the informant or the patient. What we need to know is these should be recorded in chronological order of their appearance, and we do not really have to use medical terms. That is, we have to record it in the patient's own words. Simultaneously, we need to include the duration in the presenting complaints. Next, history of present illness. History of present illness, we need to mention the time of onset of the symptom, the mode of onset, progression or course of illness, duration, precipitating and relieving factors. So time of onset. Time of onset can be early morning drowsiness or convulsion, which is common in glycogen storage diseases. Similarly, paroxysmal nocturnal dyspnea. It occurs in night, few hours after going to bed. Now, mode of onset. Mode of onset can be acute, subacute, insidious, or chronic. Progression can be either the condition becomes better or the condition becomes worse, or the condition may remain static. Next, we need to know the duration of illness. Like if the duration lasts for more than a week or is of shorter duration, like enteric fever lasts for more than a week, whereas diarrhea due to rotavirus is of short duration. Precipitating factors like chest pain and cardiac failure is aggravated by exertion, whereas chest pain in pleuritis is aggravated by respiratory movements. Relieving factors like chest pain due to cardiac failure decreases with bed rest. Next, history of past illness. Now, it is important to know what the patient has gone through till the date, like history of any infection like malaria, diarrhea, respiratory tract infection, urine discharge, allergies, UTI, any previous history of vaccine preventable disease like TB, measles, mumps, tetanus, diphtheria, history of prior hospitalization, surgical intervention, blood transfusion, drug allergy should be known. Next, antenatal history. Antenatal history includes the series of events that have occurred during the intrauterine developmental period of the child and may have led to the present illness. So here they ask what is a booked case and what is a unbooked case. So antenatal case which is registered in hospital within 12 weeks after last menstrual period is called as booked case, and if not done so, it is unbooked case. What is the significance? Records can be verified for presence of maternal diabetes or infection in antenatal period in a booked case, whereas it cannot be really done in unbooked case. Next, they ask maternal conditions that affect the pregnancy or the infant. So, if the mother has diabetes mellitus, the effect on pregnancy can be either fetal death or increased risk of preeclampsia or preterm delivery. Whereas the effect on infant would be congenital malformation, macrosomia. Macrosomia might lead to birth injuries, hypoglycemia, etc. If the mother has pregnancy induced hypertension, pregnancy on delivery can lead to premature delivery or uteroplacental insufficiency or fetal loss, whereas on the infant it leads to growth retardation and thrombocytopenia. So, what are the components of antenatal history? The components of antenatal history are we need to ask for age of the mother, weight and height of mother, immunization status of the mother, like tetanus, toxoid, and rubella, gravida and parity with number of children alive, history of abortion, interval between successive pregnancies, history of multiple pregnancies, history of complications like oligohydramnios and polyhydramnios, history of RH isoimmunization, diet during the pregnancy period, history of any disease or infection during pregnancy, drug intake, if any, with dosage and duration, symptoms of maternal malnutrition, vitamin deficiency. Antenatal history into three parts: first trimester, second trimester, and third trimester. Next, birth history. So, birth history includes the series of events that have occurred during the birth of the child. This includes first, birth order. We need to write the birth order of the baby, as if the baby is born after 2 or 3 live children, he is prone to develop malnutrition. Next, multiple pregnancy, mode of delivery, natural or cesarean, place of delivery, whether at hospital or at home or any other place, person who conducted the delivery, whether the person was a qualified doctor or nurse, a trained dai or untrained person. Gestational age, to know whether the baby was preterm, term or post-term. Birth weight of the baby, if the baby was appropriate or small or large for gestational age. Birth asphyxia, breathing difficulties, whether the baby cried or not, Apgar score at 1, 5, and 10 minutes of the birth. Now, neonatal history. Neonatal history is the first 28 days of the life of the baby. Here, we'll write about the feeding problems and the duration of feeding. If the baby is suffering from neonatal convulsions or RDS or jaundice, if, if the baby has gained weight or lost weight, history of hospitalization with duration and nature of treatment, and any congenital malformations noted in the period. Developmental history. In developmental history, we'll have to write about the milestones. I've made another video on developmental milestones, so you please go refer to that. Next, nutritional history. Nutritional history, we write the nutrition of the baby, if he is feeding, the frequency of feeding, if he is also having any prelacteal feeding, the details of that. Immunization history, we write about the immunization status of the baby. I've put up the immunization chart along with doses. The important ones would be at birth, we give BCG, OPV, and hepatitis B. At 16, 14 weeks, we give DPT, IPV, and Haemophilus influenzae B. At 6 months, we give OPV and hepatitis B. At 9, we give OPV, MMR, and typhoid. At 15 months, we give MMR. 18 months, we give DPT, IPV, hepatitis A, and Haemophilus influenzae B. For the route and the dosage, BCG is given intradermal, zero point 0.1 ml. OPV and rotavirus are given as oral. MMR and varicella are given subcutaneous, 0.5 ml, whereas other are intramuscular, given 0.5 ml. Now, family history. Family history is of significance if the disease is anywhere related or is supposed to be congenital. Now, age of the parents is important because high advanced age of mother leads to Down syndrome, CNS anomalies, premature labor, dizygotic twins. Here they ask you about consanguinity. So, degree of consanguinity, first degree, brother, sister, or parent and child. Second degree, half siblings, uncle, niece, nephew, aunt. Third degree, first cousins, half uncle and niece, or half aunt and nephew. Fourth degree, distant relatives. I haven't really mentioned about personal history because personal history is relevant if the child is more than 7 years of age. If the baby is less than 7 years of age, it does not really stand any significance. However, in personal history will include the child's personal habits, attitude, interaction with others, the diet he has, whether he's strict vegetarian or he eats mixed food, the bowel bladder habits, sleep, history of allergy, and in the end, I've put up a pedigree chart for you all, so you know the symbols main commonly used in pedigree chart. No, the important ones include normal male, normal female, affected male, affected female, consanguinity, identical twins, non-identical twins, stillbirth. That's it. So here we've reviewed shortly about case and history taking and the probable questions that they would ask us all. In the next video, we'll complete the other topic of clinical pediatrics. Until then, keep revising.